Thank you. Thank you so much. I really can't tell you how honored I am to be here. I want to thank Ms. Shiley for endowing this lecture, and I look forward to meeting her sometime. But I need to say, I feel like I'm almost an honorary member of UCSD. I was trained by Robert Katzman and Terry, and I was mentored by Leon Thal. And I go back about a quarter of a century with Dr. Brewer. I go back about a third of a century with Dr. Glasgow. I go back about half a century with Dr. Feldman. So it's really, really nice to be here and see so many old friends and things. Today I'm going to talk about mostly what I've been doing since I came to Southern California, which is studying the oldest old. And I started doing this and people asked me why I was bothering. So I'm hoping by the end of this talk you'll agree with me that it's been worth doing and that maybe the oldest old have a lot to teach us. So most of you know Jean-Louis Calment, who holds the Guinness World Record for longest lived human. I think it's rather interesting that this happened more than a quarter of a century ago, and nobody has broken her record today. Some people think that it's possible that this was not her actual age, but whether it is or isn't really isn't important. A lot of people do make it well into 118 years, 119 years, and she made it to 122. But the most important thing is what you see here in this quote from Lancet about a decade ago, which is that more than half of all children born today in developed countries can expect to reach their 100th birthday. So there was a time when 100-year-olds were so rare in the United States that President Nixon signed a birthday card personally for each of them. And now we have more than 2 million people over the age of 90. And that's nothing compared to what's going to happen, because by the middle of the century, when many of you in the room are still going to be practicing, but fortunately I won't, there's going to be about 6 million people in that age group. And the risk of dementia in these individuals was one of the things we wanted to learn with the study, because I had learned from Bob Katzman that many studies, like the Lundby study, suggested that once you got to age 90, in fact, your risk of dementia might go down. The original description and clinical criteria that we used for Alzheimer's disease, McConnell et al. From 1984, specified that you could only give the diagnosis of Alzheimer's disease to somebody who was between ages 45 and 89. And I said to him at the time, what's wrong with 90-year-olds or 91-year-olds? Why can't I make the diagnosis in them? And his answer to me was, well, we really just don't know about 90-year-olds. So it took me about a quarter of a century to remember those particular words, but believe me, I've thought of all the things he told me so long ago really often, and then I decided maybe it was time to find out about 90-year-olds. And so that's why we started the 90+ study. So the first thing I'm going to do is give you a little background on the study, and actually I decided to cheat. I'm going to do about a 3-minute clip because Leslie Stahl is more interesting than I am. And then I'm going to talk about risk factors related to cognition, causes of dementia and attributable risks, some unpublished data that I think is really important, and musings on resistance and resilience. Now I have to tell you, I did not pick the title of my talk. I had a very boring, like 4 or 5 word title, which is what I usually do. So it's Dr. Brewer's fault that I have that title, and I'm trying to get most of the words that he put in the title somewhere in the context of this talk. So the 90+ study at this point is actually a volunteer cohort, but it began with a population-based sample, because in 1981, USC sent out a questionnaire to everybody who was living in a community at the time called Leisure World. So it's the Leisure World cohort study. Now it's called Laguna Woods. It happens to be in our backyard at UCI. They sent out 18,000 questionnaires. They got 14,000 of them back. And that's the population sample that we used in 2003 when we said, if on January 1st, if you're alive and one of those 18,000 people, and over the age of 90, we wanted you. At this point, we have more than 2,000 individuals because we've been working, and hopefully, if we get renewed, are going to work even harder on diversifying our cohort, because the cohort is primarily white and fairly well educated. So this 60-minute segment was done a number of years ago, and it actually was a 30-minute segment, but I've got about 3 minutes introducing the study that I thought I'd show you.
We're a nation getting older. By the middle of the century, the number of Americans aged 90 and above is projected to quadruple. Dementia, including that most dreaded form, Alzheimer's disease, is a looming threat and a primary focus of the 90-plus study.
I was born on August 25th, 1920, and I'm 93 plus.
1918.
What they have in common is that decades ago, they all lived in a retirement community called Leisure World, 45 miles south of Los Angeles. Today, it's still a retirement community, and they're still getting the most out of life, though it's no longer called Leisure World. It's now its own city, Laguna Woods. Dr. Claudia Kawas spends a lot of time in Laguna Woods these days. She's a neurologist and professor at nearby UC Irvine who discovered the research equivalent of gold here. Information gathered from thousands of Leisure World residents back in 1981, with page after page of data about their diet, exercise, vitamins, and activities. $6 million of funding from the National Institutes of Health. Kawas and her team set out to find out who had died, when they died, and to convince those who were still living and over 90 to sign up.
Now please spell world.
They are given an hour-long battery of cognitive and memory tests.
Good. Now spell world backwards. D-L-R-O-W.
They are checked from top to bottom every 6 months.
Big smile.
Their facial muscles, reflexes, balance,
3, 4, 5.
how they walk, how fast they can stand up and sit down, and most importantly, how their minds are working.
You know, unfortunately, there's no blood test, there's no x-ray. It's an examiner finding out that an individual has problems in 2 or more of the main things the brain does for them.
So what was it that got these people into their 90s?
So you've never had a stroke?
No.
While their spouses, friends, and colleagues
Never had hardly anything?
dropped out along the way.
What's your secret?
I wish I knew.
Well, whatever your secrets are, by being in the study, we're going to try to find them out.
Comparing that data to how it's all turned out has yielded a slew of published findings about behaviors associated with living longer.
I really believe that when we learn things from the 90-year-olds, they're going to be helping the 60 and 70-year-olds, not just how to become 90-year-olds, but how to do it with style and as good a function as possible.
So, the Leisure World cohort study was just a mailed survey, 14 pages that got mailed back, but we wanted to see these individuals. And although they all lived in Laguna Woods or Leisure World in 1981, we had to go to 37 states to find them. And not only that, we see them every 6 months. So, for example, the staff was devastated when the person in Hawaii died or the person in Puerto Rico died. They always made sure they would go there, at least in the winter, if they could one time. And when we see them, we ask so much of them. I mean, we collect a lot of information. We give them neuropsychological tests and physical and neuro exams. We have a lot of informant information, medical record information. We ask them for their DNA. At this point, we are putting them into 3 images. We do amyloid, tau, PET, and also MRI, and we're talking about repeating some of them. And at the end of it all, we ask them if they will give us their brains, which is actually one of the most important things that's, in terms of helping us understand what's going on. So at baseline, this is the first 1,600 people from the population sample. What you see is that by age 90, there are 3 women alive for every man. Now, to me, this is a Nobel Prize question. Why is it that on virtually any species on the planet that has a difference in longevity by sex, it is always the female that lives longer? And when I was in medical school, it doesn't really matter when that was, it was just a long time ago, they told me it was because women had less stress in their life. So, now, although a significant number of these individuals are living in some kind of sheltered living or group home, or perhaps they moved out of Laguna Woods because they moved in with family, about a third of them were living alone with very little, if any, outside support. In terms of cognitive diagnosis, it was about a third. And that is, about a third of them we felt were essentially normal, a third of them we felt had dementia, and a third of them fell in that in-between zone that includes things like mild cognitive impairment or some other cognitive deficit but didn't meet criteria for dementia. So one of the first things we wanted to know is if you made it to age 90 without having dementia, what was your risk over the next few years of developing dementia? Did the risk go up? Did the risk go down? Did it continue to double? So here you see, these are studies that are much more recent than when I started the study, but what you see is that at age 75 or at age 80, the estimates from almost every study, no matter where it is in the world or how it was done, is pretty similar. But once you get to age 85, and even more when you get to 90, and forget it when you're up to 95, the estimates were all over the place. Now, I don't think that we should tell the people in Munich, Germany, which is that purple top line, that they need to move to Sao Paulo, Brazil, which is the bottom blue line. So what's going on here, that there's a tenfold difference in the range of estimates. And I actually had hypothesized that the risk was going to go down. You see, even on here, some of the studies show an increase in risk. Some of them show a decrease in risk after age 90, or a leveling off at least. And I wanted it to decrease or level off. And when we finally were able to do the study, in fact, what we found out was there is a perfect doubling. So at age 90 to 94, the risk was about 10% per year. 95 to 99, 20% per year. And by age 100 or 100 plus, a staggering 40% per year. And no matter how high this is, it doesn't mean that everybody develops dementia. I mean, we routinely, a couple of weeks ago, we had a 105-year-old die who not only had good cognition, but a brain that the pathologist said they hope theirs looked like right now, right? So a lot of variability in aging, both in clinical abilities and also in pathological findings. So the risk is very, very high. It is so high that when this group in the middle of the century is 6 million people, we are going to have more dementia above age 90 than we currently have in the United States at all ages put together, including 90 and 100-year-olds. So it's a huge public health issue, and we wanted to learn more about it in hopes that we can do something. So our first thing was, in 1981, they had reported whether or not they were taking vitamin E, vitamin C, their BMI, their alcohol intake, a variety of these things, many of which, have been associated with dementia in the past. And so we wanted to see if they were related to dementia in our 90-year-olds, and not a single one of them was. In fact, ApoE4, which we all know is the strongest genetic susceptibility factor, is not associated with incident dementia in people over the age of 90. We had at least 3 individuals who entered the study who were 4/4s. They were homozygotes and did not have dementia when they enrolled in the study. So even the genetic risk factors for Alzheimer's disease and certain dementias does not appear to be operant in this age group. So we were hoping we'd find something that was relevant. The next thing that we looked at was cardiovascular and cerebrovascular disease. And here we got much more of what we expected. So you see that individuals who had congestive heart failure or a stroke or heart valve disease, had essentially double the risk of developing dementia compared to individuals who didn't have those conditions. And that wasn't a surprise, and that was pretty much what you would predict at more or less all elderly ages. But what surprised us was at the far right of this graph, where individuals who reported a history of high cholesterol or reported a history of hypertension actually appeared to have a 25% reduction in risk of developing dementia when compared to individuals who never developed hypertension in their entire life or never had high cholesterol. So we're talking about a protective effect here, not just that the risk went away, but now those things are protecting these individuals. Now, at first I thought I understood, oh, this is just, that's because people who are hypertensive are taking medicines and probably their blood pressure is even lower, and I had all kinds of ideas. None of them were true. And when we finally published this, I was interested in how many people said to me, we found something like that too, but I was afraid to publish it because, if the type 1 error matches what we think, we're happy to publish it. But if it doesn't match what we think, we just think it's a type 1 error and we shouldn't publish it. We have turned this particular finding upside down and right side over, and it turns out it's not just the history of hypertension that matters, but when you developed hypertension. So here you see the individuals who said they had hypertension, but they didn't know what their age was, or said they developed it below age 70, or they developed it from 70 to 79. And keep in mind, this is a treated group, essentially. They are all receiving treatment for their hypertension. But those individuals did not appear to have an elevated risk of dementia or a reduced risk of dementia. It's only people who were told they developed hypertension after age 80, or even more so after age 90, where there is more than a 50% reduction in their risk. This is a work in progress. We are hoping to be able to tie this to some explanation. My favorite right now is that, we do all these studies like Framingham and 50 and 60 and 70-year-olds, even most ADRCs are only a mean age probably in the 70s. But the vessels of a 50, 60, 70-year-old and maybe the blood pressure that's optimal for a 50, 60, 70-year-old doesn't appear to be relevant to 80 and 90-year-olds. And potentially you need more pressure in order to maintain perfusion or some other things like that. We're working on this. I'm hoping some of you will work on it too. Now, when we are lowering the risk of dementia, or when we see this, the real question is, what is causing the dementia in these individuals? I've spent my entire career hearing that Alzheimer's disease is the most common dementia. Most people say it accounts for about 70% or even more in elderly individuals. And so we wanted to see what we would find in the 90-year-olds. We've enrolled actually more than 600 people now in the autopsy study. We have actually almost 500 brains, and I'm going to show you some of the results that we've gotten. So the first thing is, okay, if you had dementia, what's the likelihood that I would find Alzheimer's pathology in your head? And here we got what I think everybody would predict. AD pathology, here it's shown intermittent and high levels, is actually the most common pathology that we find by far. It is in 60% of individuals who have dementia. But then you look at the people who don't have dementia, and it turns out that 40% of them also have intermediate and high levels of AD pathology. Now, depending on how old you are, you were either taught that those individuals in that group and the no dementia are actually preclinical. That is, they're at high risk. So we design prevention trials, and we go out and we look for these people, and we try to find people who are normal but at least have amyloid as shown by some kind of scan, some kind of blood test. And we do that because we believe, at least when we do the prevention trials, we believe that that's because we're enriching, you're at higher risk, we're more likely to get a result. But lately, people have been using that exact same definition for what they're terming resilience. I have a lot of discordance when I think about this. I can't imagine that the same thing is high risk in one person and resilience in the same person or another person, or maybe it is, but I can't tell the difference. But resilience has become a very, very popular concept. I think in favor of this being preclinical disease is that every model we've looked at, whether we're talking about genetic models, or we're talking about mouse models, or we're talking about Down syndrome, we know that at least amyloid begins being deposited on average 15 years or more before clear symptoms begin. So to me, that's a pretty good argument that this is preclinical, and the individual, if they had lived longer, might have developed dementia. But everybody likes the idea that at least when I find this in 90-year-olds, that maybe it's resilience. And so we've been trying to look at resilience with a number of definitions. But the story, if you just look at this and you think that all this dementia is due to Alzheimer's disease, you've really not taken into account the most important finding, I think, that we've found, which is that 70% of all the brains in our brain bank, whether they have dementia or not, have 3 or more dementia-related pathologies. So almost nobody has pure anything, and there's every combination imaginable. And when you start putting some of those on this graph, what you see is, for example, vascular disease and microinfarcts, they start loading primarily on the dementia side, not the no dementia side. And then when we added hippocampal sclerosis, you can see it almost all loads on the dementia side. And we're talking about big chunks, and we're talking about a lot of overlap. I don't even have TDP on this slide because as you're adding things, it becomes impossible to show the degree of overlap. But the number of these things that you have matters. It matters, first of all, for the risk of dementia, and you can see that in the left panel. That is, by the time you have 3 or more, 95% of those individuals have dementia. But it also matters for the severity of dementia. So if you have only Alzheimer's disease, for example, which is that number of pathologies 1 on the right, you have dementia. But if you have more pathologies, you have increasing severity of dementia. And this group that's labeled as 0, that had no pathologies that we could identify, but had the mildest form of dementia, and have always been an interesting group to me, and it's going to turn out that much of that group has disappeared when we finally started looking for TDP. And I will talk about that later in the talk. So how many you have matters for whether or not you have dementia. It matters for the severity of dementia. You've got all these things in the brains of these individuals, and what we wanted to know is what was the attributable risk of each of these pathologies. Another way of looking at this is, suppose we developed a cure for a pathology like Alzheimer's disease tomorrow, and we absolutely could get rid of every plaque, every tangle, all the dementia that's due to plaques and tangles. How much of the dementia burden would we get rid of in individuals? And anyone want to take any guesses? How much? Not a lot. Well, not 70%. That's a good guess. It turns out we'll only get rid of about 1/4 of dementia in this age group. And actually, this calculation's been done, for example, by the Rush people who came up with something similar. Of course, the mean age in their autopsy study is in the something like 88 or 89. But right on the heels of that 25%, you'll see at the other end, arteriolar sclerosis. Here's where I feel like I've really come full circle. I'm old enough that I remember when dementia was called hardening of the arteries. And in between, when I learned that and now, I, for the most part, have not considered arteriolar sclerosis or atherosclerosis to be causes of dementia. I consider them to be related to infarcts, small, large, and micro, but not themselves to be related. But what you see here is that actually independently of any kind of stroke, they still account for almost a quarter of the dementia. And one of the things that was striking is that all levels of arteriosclerosis was related to dementia, mild, moderate, or severe. Atherosclerosis, only severe levels were related. But in our cohort, we've got as much dementia, we believe, that's attributable to arteriosclerosis. And following right on its heels, you see in the middle, is TDP, what we now call late, for good or for bad. Now, when you put all the vascular together, you'll see that it accounts for almost half of the dementia. That's putting arterio, athero, CAA, microscopic infarcts. We didn't have any big infarcts, but they would have gone in this group. I think a more simple, the thing I also wanted to point out here is that when you put all of these pathologies now, we still have 20% of the dementia in our cohorts that's unaccounted for. So I think there's something else besides TDP, besides microinfarcts, besides arteriosclerosis. We still have more things to discover because we don't account for all the dementia in our group when we do the proper calculations. So here you see it in a kind of neater form. You can see that far and away the vascular as a group account for the most. Alzheimer's disease and late follow up. Lewy bodies really doesn't do a whole lot in this cohort, although it accounts for 5 or 6% of the dementia. Which brings me to late. Now, somebody's, I'm sure, got feelings about how this was named. I kind of was laughing the whole time, and the main argument was whether or not the E should stand for encephalopathy or something else. And my feeling was, I'm just trying to figure out how I'm going to tell patients that they have late. But late stands for, as you see here, limbic predominant, age-associated TDP-43 encephalopathy. Most of you might know that TDP is associated with other diseases like ALS or Lou Gehrig's disease. So it came somewhat of a surprise, I think, when we realized that in a different distribution, we see this very commonly in older individuals. It is strongly age-related, and essentially that's the only risk factor right now that I feel is absolutely clear. We see it almost never before age 80. Starts becoming quite common in age 90, even more common in age 100. So the risk is very strongly age-related, as is Alzheimer's disease and most of the other pathologies we looked at. The primary symptom is memory loss. And unfortunately, it looks to many of our eyes to be very similar to Alzheimer's disease, as I'm going to show you in a second. In retrospect, we look at these individuals and we think that they tend to have slower progression than the average Alzheimer's patient. Another problem is it frequently co-occurs with Alzheimer's disease. So individuals who on autopsy have high levels of Alzheimer's pathology, about 50% of them also have late. But individuals with no Alzheimer's pathology at all, I'm talking now about low or no AD, 25% of those individuals in this age group also have late. And if you have either of those two, you are likely to have dementia. But if you have both Alzheimer's disease and late, you have a more severe dementia and you have a faster rate of decline. It can't be diagnosed during life. I say that yet in hopes that somebody is going to help us with that. At the moment, we have finally bitten the bullet, and some proposed clinical diagnostic criteria is being submitted to a journal. It's going to be rough going, but the pathological criteria was first published only in 2019. There was an updated criteria a couple of years later with some refinements, and through all of this, I felt very strongly that we had not enough information to try to make a clinical diagnosis, but at this point, I don't think we have a choice. So I want to show you two more minutes, actually, from the 60 Minutes show. It is a great example of, I know I'm a terrible diagnostician, I mean, I've always known that. I know that a lot of other clinicians seem to be very comfortable just saying, this is your diagnosis. I've always told the patients, you know, this is what I think, but you know, there's no way to tell unless we do an autopsy. But most people don't go on national television and show how bad their diagnosis is. So in the first show that we did with 60 Minutes, most of the individuals were very successful agers, I would say. You saw them jogging and swimming and doing all kinds of things. And one of them felt a need to talk about sex and why didn't we study sex enough, and he put that on national television. But we did have one gentleman who had cognitive impairment, and this is what he looked like.
As charming and engaging as all the 90-plussers we met were, one who we were particularly moved by was 96-year-old Ted Rosenbaum, a former American history teacher who's been married for 63 years.
You still look lovely to me. I was very lucky. So now at this stage of the game, if it's petering out, just reminiscing about our past is a source of incalculable joy.
An orange and a banana are alike because they're both
Fruits.
exactly.
Ted did well on parts of the 90-plus exam, like repeating long strings of numbers backwards.
6, 1, 8, 4, 3.
3, 4, 8, 1, 6.
But when it came time to remember the 3 words she had told him just 40 seconds earlier,
3 words.
Yeah.
Give me a hint.
he was lost.
3 words.
And that wasn't his only problem.
What is today's date?
Today's date? Today's date.
Does he have dementia at this point?
Yes, Ted has dementia. You know, unfortunately, there's no blood test, there's no x-ray. It's an examiner finding out that an individual has problems in 2 or more of the main things the brain does for them. So that's where he is.
And what's perhaps the most devastating is he knows it.
My worst condition is my memory.
When you can't remember something, what goes on inside you?
Terrible frustration, terrible, you know, it's having more and more of a negative impact on me psychologically.
So I didn't have the heart to look back at the whole segment, but I think it's a pretty safe bet that I was on camera saying I thought he had Alzheimer's disease, because to me he looked like pretty garden variety Alzheimer's disease. And 6 years later, when 60 Minutes wanted to do a follow-up, they showed the individuals who were still alive and how they were doing, and those who were deceased, which included this gentleman, we showed the autopsy. There was no Alzheimer's disease in Mr. Rosenbaum's brain. He had nothing except late. So I think he's a really good example, actually, of the kind of criteria and the clinical syndrome that we think goes along with pure late, which in the criteria that we're proposing is going to be probable late or possible late, somewhat akin to the Alzheimer's criteria, with definite, of course, reserved for autopsy or hopefully and eventually some other biomarkers. Now, resistance and resilience. So a number of years ago, the concept of resistance and resilience started becoming popular. There were several articles, including this one, which we published with Lon White and Tom Montine, trying to give some operational definitions for the concepts of resistance and resilience. And basically, resistance is the idea that you don't have the pathology, right? So, for example, in our site, about 20%, and it surprised me how high this was, but 20% of our 90-year-olds who come to autopsy have no amyloid, CRAD stage 0. And I didn't expect that. I thought that it would continue to rise and that particularly in 100-year-olds it would be almost 100%. But 1 out of 5 individuals who make it to this age range are actually resistant to Alzheimer's pathology. Nonetheless, more than half of them have dementia. So just because you don't develop Alzheimer's disease doesn't mean you don't get the other problems, right? Resilience has been defined in a lot of different ways, but basically it's when we think that the person is doing better than they should be doing based on what we find in their brain. And I'd say it was at least a third of a century ago that Bob Terry published a paper talking about individuals with preserved cognition who came to autopsy and had significant Alzheimer's pathology in their brain. Now, once again, I want to remind you, this could be preclinical, this could be resilience, but that's the definition that people are using for resilience. So when we have somebody who comes to autopsy and is normal, but they have Alzheimer's disease, we call them resilient. And gee, we want to study this because we'd like to make everybody resilient. The last thing I want to point out about these concepts, and I think this is maybe the most important thing, most people, when they're using the term resilience especially, are purely talking about resilience to Alzheimer's disease. First of all, that's the only one really we even have a chance of identifying during life with our scans or with our blood tests. But I think it's really important that we consider these things in the context of all pathologies, resistance and resilience to all pathologies. So if you look here, what you see, the first panel where it says AD alone, those are individuals who have only significant levels of Alzheimer's pathology. That is, they are resistant to non-Alzheimer's pathology because they don't have any others. And their risk is elevated with an odds ratio of about 3.5. If you look at the same thing for individuals who only had one pathology, but it was one of the non-AD pathologies, any of them, we put them all together, now you see the odds is 12.5. I mean, that's a whopping odds ratio for a study. So when you have a non-AD pathology, your likelihood of having dementia is a lot greater than when you have only Alzheimer's disease. That means there's not a whole lot of resilience to any of the other pathologies. Now, if you take Alzheimer's disease and you add a second pathology, so people who now have two, one of which is Alzheimer's disease and one of which is something else, you see an odds ratio that's similar to non-AD. But when you take two non-AD and add them together, you don't go anywhere. The severity gets worse, but the likelihood of dementia. So all the action really is happening in people who have more than one pathology, of which non-AD pathology seems to be the main driver. And a few years ago, we published this, and we've looked at this now every way. We've looked at it in dementia versus non-dementia. We've looked at the other end of the spectrum, super-agers versus non-super-agers. Some of this is not published yet, but the bottom line is pathology seems to really, really matter. When we did this paper with John Trojanowski and John Robinson, our basic conclusion was that if you take people with Alzheimer's disease and divide them into those who have dementia and those who don't have dementia but do have Alzheimer's disease, the basic difference between them was less of everything else. So less cerebrovascular disease in the people we were calling resilient, no hippocampal sclerosis at that time. I think we might have one now. Less cortical ARTAG, less late, less Lewy bodies, and our conclusion was that our findings imply that reductions in non-AD pathologies, including vascular disease, that 40% that I showed you of attributable risk, really is what's contributing to resilience in the oldest old. I mean, I've said for a long time, if I had to have one pathology in my head, please make it be Alzheimer's disease, right? Everybody thinks that's what they're fearing the most. That's not the thing to fear the most. You want to fear all the vascular disease, the Lewy bodies, the TDP, everything else seems to be more strongly related, at least in this age group, and I suspect even in younger individuals. So some important questions I think are there for resilience in particular, and that is amyloid deposition and other pathologies, tau, late vascular disease, if the person doesn't have cognitive loss, is that resilience or preclinical disease? Is resilience to Alzheimer's disease actually just the absence of other pathologies that we can't see during life yet or don't have any easy way to diagnose it? And what factors are associated with resilience and resistance to all of these pathologies? Because as long as you keep me from getting all the others, I think 75% of dementia would disappear in this age group. And all these things have sort of come together to make me not completely comfortable with the idea that there really is true resilience, that at least to other pathologies, and then maybe even to Alzheimer's disease, that it's not that the person is resilient to Alzheimer's disease, it's just they don't have other things going on. And then when I'm sure that that's the case, then I see somebody like this gentleman. So this gentleman's not unique. He is one we published, however, as a case report. He was a 96-year-old man, and he had not just normal performance, but superior performance. You can see here, his mini-mental up until visit 13 was up in the 90th percentile, which is what you see in the blue lines. The green line is mean, 50th percentile, and the red line is 10th percentile. Boston naming, CVLT, after the first visit, he learned all 9 words, and he knew them for the next 12 visits, and that visit 13, by the way, was 4 months before he died. So we have information about him all the way through there. And maybe the other thing that's quite interesting about him is that he's an ApoE4. So we get his autopsy. Well, actually, first we got some scans, so we knew just on CT scans that he had bilateral lacunar infarcts that were visible. And when we looked at his autopsy, he had intermediate Alzheimer's disease with very high amyloid C3 scores. Tau was only 4. Very high Lewy bodies, 5 out of a staging system that goes up to 6. High TDP, or average, medium, moderate TDP, 2 on a staging system that only goes to 3. So he had a lot of pathology in his brain, and yet really managed to maintain cognition right up until his death. So maybe this is the kind of resilience that I'm hoping we need to study. So in summary, a remarkable increase in longevity. We've added 27 years in the last century to life expectancy. And the numbers of oldest old, not just in the United States, but worldwide, they're the fastest growing segment. The risk of dementia and cognitive decline in these individuals is exceptionally high. But it's not related only to Alzheimer's disease, it's related to a lot of pathologies, and they're additive at bare minimum. Many individuals, nonetheless, seem to maintain cognitive abilities, even in the presence of neuropathologic changes. I don't know if this is resilience or risk, but somebody is going to figure it out, I'm sure. But I can't help but notice at the end of the day that 2/3 of all dementia in this age group is actually due to vascular pathologies and TDP late. And we really need to start putting some attention into those pathologies, including the development of biomarkers, clinical criteria, new treatment approaches, because we haven't done that during my entire career. The emphasis has been on amyloid in particular and Alzheimer's disease in general. I think we have a lot to learn about cognition and aging, and I think the 90-year-olds are very good people to look at to try to teach us. So big acknowledgments, especially to the participants, their families. Thank you so much to all my colleagues and co-investigators and collaborators, particularly Maria Carrata, who's been my co-PI for the last decade, and the National Institute of Aging, without which we would be nothing, since they have funded us for the last 20 years, and we hope we'll keep going. Thank Thank you for having me.
That was outstanding. We really appreciate it. And if my title had anything to do with how great that talk was, I'm very glad. So we'll take a couple questions.
Secular changes, in particular for things like vascular disease. So folks in your cohort might have lived through less rigorous standards for diagnosing hypertension, smaller repertoire of drugs available for management, less clinical attention and rigor, and perhaps things like more smoking at different life stages. Do you think any of those factors on their own are perhaps going to change the impact? We've certainly seen this in stroke, where we see fewer big strokes than we used to, even from what I remember from my early career.
So excellent thing to point out. So Dr. Glasgow is asking about secular, or what I would call cohort changes over time. A number of years ago, people started publishing data to suggest that the risk of dementia, and maybe the risk of dementia due to what, I'm not sure, but the risk for all-cause dementia over the last 2 decades appears to have gone down. And at first, truthfully, I didn't really believe it. My attitude was kind of, we're diagnosing it differently, you know, there's all these, I mean, it's not just things that have changed in people, but the investigators are doing it differently. Then more and more people started finding these trends, not just in the United States, but also in Europe. And what I said to people at the time, when I finally believed, I do believe that the risk of dementia, age-specific risk of dementia, has gone down over the last 2 decades. I'm convinced now. And I'm liked that we observed that before we had a single therapy. Because the one thing that I know for sure is whatever made it go down, it's not a pharmaceutical company, right? At least not in the form of Alzheimer's therapy. But it might be in the form of treating hypertension. It might be in the form of treating cholesterol. It might even be that some of those drugs, like statins, have their own effects and are also reducing the risk. It might be that smoking has gone down. It might be that education has gone up. So I do think that the risk has gone down. And then when I see this 40% vascular attributable risk, and I know that from a public health standpoint, that's been the biggest thing we've done for half a century, the amazing attention to treating hypertension and high cholesterol to reduce the risk of stroke, it makes sense to me that it probably is largely responsible for any declines we've seen. Does that answer your question? No?
Well, Claudia, I want to just thank you so much for enlightening us today. And truly, you've been an inspiration for us. You set the standard for optimal characterization of cohorts in a cognitive, clinical, and biomarker approach. And you're just fearless in your way. You really are. You challenge the dogma, and that's really an inspiration for us. So in recognition of that, and for recognition of making another Shyly Endowed lecture a tremendous success, I want to give you this token of our appreciation.
Thank you so much. Thank you. Thank you so much.